Hello, I'm Professor Mark Whiteley of the Whiteley Clinic, and I'm here today to talk to you about the NeverTouch Direct system of endovenous laser ablation. We're going to talk about the NeverTouch Direct system, which comes in this package, and we're going to go through what's in the package and how to open it first. So this is the NeverTouch Direct gold-tipped box, and when we open it first of all, we find that inside there are two different packages. These two different packages are sterilely wrapped. The first one is the introduction kit, and the second one is the NeverTouch Direct fibre. First we're going to look at the introduction kit, which is in its own sterile sachet, and this can be opened and handed directly to the scrub nurse or the surgeon depending how your clinic is set up. This can be dropped straight onto the table, or of course they can pick it out of the sterile wrapping itself. The first of the three parts of this kit is the micropuncture needle, and I must say that this is one of my favourite parts of the whole kit. It's so thin that we can get into virtually any size vein, and it's very easy to see on the ultrasound. It's also very sharp, and when you get into the vein you get just a little bead of blood coming back into this area here, and that means you can see exactly where you are. The second part is the small introduction cannula that has to go inside the vein. Unlike the older kits which had a very long laser sheath that the laser fibre went up inside, the NeverTouch Direct only needs access inside the vein, and therefore we're able to use this very small and thin cannula. To get it in using the Seldinger technique, we merely flush this with heparin, and then we pass this dilator all the way inside until it comes out of the other end, and simply it clips together. Once it's clipped together, this can be passed on the end of the wire into the vein itself, and once it's in the vein this gives us a very low profile access into the vein itself, for which the NeverTouch Direct can be introduced into the vein and positioned. The third component of this kit is the very small introduction wire, and this can be passed down inside the micropuncture needle when in position, and as you can see it's a very fine but quite short wire. It only needs to be short because, of course, unlike the older systems which go right up to the saphenofemoral junction or the saphenopopliteal junction, this only has to go just far enough to allow the cannula to be inserted into the vein. The second package within the NeverTouch Direct kit is the laser fibre itself. This is in its own sterile envelope, which once again can be opened up and handed to the scrub nurse or to the surgeon themselves, depending who wishes to do the procedure. And this is actually worthy of a bit of looking at, because this, what many companies use as card, is actually a plastic and a very well organised plate to really hand over to the person doing the procedure. The NeverTouch Direct fibre comes recoiled in this special die card which holds it in this configuration. Anyone who's used endovenous laser knows that one of the problems is when you take the fibre out, it just springs everywhere. It can spring out of the operative field, and once it does that, of course, it can become unsterile. The AngioDynamics NeverTouch Direct system has used this very ingenious method, and this is the way it works. Firstly, when it's opened up and it's all sterile, this end, which is a special SMA connector, can simply be taken out of the die card, and just enough of it is required can be handed out to the circulating nurse to be put into the laser. Once that's been connected to the laser, the other end can then be removed, which is the NeverTouch Direct with the gold tip, and this can be handed out into the surgeon, and just enough can be handed that is required. So if it's a short section of vein, like an anterior accessory saphenous vein that requires just 20 or so centimetres, you'd only take a little bit out, whereas if you wanted a longer amount, you can keep on unwinding as much as you require. And as you can see, by doing this system, the die card holds the rest of it nice and compactly within the operative field, so there's no risk of it springing away. The NeverTouch Direct fibre itself is well worth looking at, and there are a couple of features worthy of note. Firstly, it's one of the narrowest fibres that's around, and it fits straight down a 4 French gauge cannula, meaning that the access is absolutely tiny. The fibre itself is coated with this nylon external coating, which means that if a tumescence needle touches it, it'll bounce straight off without causing any damage. At the Whiteley Clinic, we've published previously, using bare tip fibres, that it is possible to damage the outer coating of a bare tip fibre, and that fibre then can actually, when it's fired, can cause damage to the whole fibre itself, and in one case we even saw it break. However, using the NeverTouch Direct, this can't happen, and the tumescence needle touching this will bounce straight off, leaving the fibre completely undamaged. As with all endovenous devices, there's 1 centimetre markings all the way along the shaft, so we can work out exactly how fast we're pulling it back and what the linear endovenous energy density is, or LEED. So every 1 centimetre there's a mark, and every 10 centimetres there's a double mark for 20 centimetres, triple mark for 30 centimetres, and so on, so we can work out exactly where the tip is, even if we're not scanning it at the time. Looking at the end of the NeverTouch Direct fibre, we can see several features that are worthy of note. The first is the gold tip, or the gold jacket. This is a cylinder of metal that holds the fibre away from the wall, allowing the beam to come out to the end, causing the heating, without the tip actually touching the wall. By doing this, it reduces the risk of any perforation, and therefore reducing the risk of ecchymosis or hematoma, reducing pain for the patient and getting a more concentric closing of the vein. We can then see the marking, and we can see this group of white marks that from the end coming all the way along get closer and closer together until some 3 to 4 centimetres away from the tip they're almost confluent. This means that as we're pulling the fibre out through the skin, we can see the normal marks here on the blue showing every centimetre with a little white mark, until we come into the last few centimetres, and we can see at that point these marks start getting closer and closer together. These markings are particularly useful when we're using the skin as a reference point and we're withdrawing the NeverTouch Direct fibre. At the end of that confluence, in most patients, that's when we would stop the treatment. If we have very good ultrasound, of course, when we start seeing these, we can check that the end is still in the vein. And also, if we know we've got a particularly large patient or a very deep vein, we can actually elect earlier on to stop earlier before we get to the confluence. So this really is a warning saying that the tip is coming near the surface and allowing us to make sure the treatment stops while the tip is still inside the vein. I'm now going to demonstrate the endovenous access, and this is using, first of all, the micropuncture needle. So under ultrasound control, what we would do is we would insert this micropuncture needle into the vein, and then we'd use the ultrasound to make sure we were exactly the right place. Using this model though, you can see we've got a flush back, just as we'd see in the normal patient. Where we've got flush back here into the end of the micropuncture needle, we can then get our guide wire here with the little introducer, and we can put this straight down the end of the micropuncture needle. And once we're in place there, we can push the wire up inside the vein. And once again, once this guide wire is inside the vein, we can use the ultrasound to make sure we're in exactly the right place. Once that's in position, and we can see where we are, we can then remove the needle, leaving the guide wire in place, ready for the cell dinger technique. And you can see tiny little hole here, which in the real patient would be really tiny access. Once the guide wire is in place, we can then put the introducer in, and this is the NeverTouch Direct introducer, which as you can see is very small. It's beautifully tapered, so as it goes through the skin, it will just dilate the skin, making a very small passage, and at the end you won't even need a suture at all. A little steri-strip will be enough to close the wound. So what we do is we just pop the guide wire into the end of the introducer, and before we pass it into the skin itself, we just make sure that enough guide wire is coming out of the other end. This is essential, as within all catheter techniques, because if we push blindly through at that point and weren't holding the wire, then what could end up happening is the wire could be lost inside. So making sure we're holding the wire safely, we can then just slide this introducer straight into the vein. And once we're in this position here, we can then take out the wire and the introducer, leaving the cannula in place. Once we've got access into the vein using the cannula, we can then put the NeverTouch Direct fibre into the vein itself through the cannula. When it's going to come to measuring on or the pulling back, we can either use the end of the cannula here or the skin Due to this specialist marking, it's preferable to use the skin because then we know exactly how deep we are and how far away the tip of the fibre is from the skin at the end of the treatment. So placing the NeverTouch Direct fibre in through the cannula, we can go all the way up inside the vein, and of course in real life we then use ultrasound to see exactly where we are at the top. We can then pull this cannula out, keeping the fibre exactly where it is, and for positioning. Once we're in this position, we can then use the ultrasound to show that the tip of the NeverTouch Direct fibre is 2 centimetres back from the saphenofemoral junction. And so we can then measure here and measure against the number of markings, and so we can mark down exactly where we are at that position. At this stage we would then put tumescence all around the fibre, and once again this would be under ultrasound control, and the patient would be placed in the head down position. Once the tumescence is safely around the vein and we're happy with the top position, we can start our pullback with the laser on. So the laser will be set to the correct wattage, and then once we're firing the laser, we'll pull it back smoothly and continuously, counting how many seconds each centimetre takes to come through. By multiplying the number of seconds by the wattage for each centimetre, we can work out the LEED, or linear endovenous energy density, to make sure we're closing the vein adequately. As we're doing our pullback, we'll get near the end, and we'll be warned about this because we'll start seeing the large white marks coming, and we know we're within a few centimetres at the end. In a normal sized patient, or one where the vein is only a centimetre or so deep to the skin, we'll keep on pulling back and keep treating right up until these white marks become confluent. In a larger patient, or a patient in whom the vein is deeper, we may elect to stop earlier, making sure that we're not putting the fibre through any fat tissue and making sure that the treatment is restricted to the vein only. In a normal patient, we get to the pullback section where we see the confluence of the white marks, and as we can see these 3 in a row and it starts going blue afterwards, we would stop at this point. When we withdraw the fibre, we can see that we've got about 3 centimetres left deep inside. So if we use the skin as the marking point, we can use these white marks as we've just shown to know exactly where the gold tip is, so we know at the end of the treatment. However, some people, myself included, like to keep the sheath inside through the skin so that we protect the skin and make sure there's no chance of any accident happening or any skin burns. To do that, what I like to do is measure just before we start. We push the fibre into the sheath, making sure that the gold tip has come all the way through, plus a bit extra, because this is the point we would want to stop treatment. We can then count back on the outside. There's the double mark here, which is 20 centimetres, 19, 18, 17, 16, 15, 14. So wherever I'm holding the sheath on the leg, and I can position it to whatever point I want inside the skin. We can have the skin at this point, this point, this point, this point. We can make it anywhere at all. But when we get to 14 centimetres on the outside, we will know that the gold tip is just outside the end of the cannula. If we go further than that, we will actually be withdrawing into the cannula and we'll end up burning the cannula, and that way we could get some damage. So if the sheath is within the skin, and say the skin is maybe at this point because you've pulled it back to that area, once you've got to the 14 centimetre mark, which we know correlates to the gold tip poking out at the end of the cannula, at that point we will have finished our treatment and we would withdraw the whole of the assembly out through the skin with a laser in the off position.